All right, good evening, everyone. I'm Arjun Sebastian. I'm an orthopedic spine surgeon here at Mayo Clinic in Rochester, Minnesota. I'm joined today by one of my senior partners, Dr. Ahmad Nassr, who's also an orthopedic spine surgeon here at Mayo. Today, we're going to be talking a little bit about cervical deformity. And so we'll try to present some cases and also maybe go over some relevant literature and sort of tips and tricks. And we appreciate the opportunity to present this and thank the Seattle Science Foundation for providing us with this opportunity. So getting into it, I also want to acknowledge Dr. Courier. He lent us some slides and some of his cases for this presentation as well. And some of the objectives for today's case presentation here is hopefully to get a better idea of how to evaluate these patients, how to look at alignment measurements, and go over some of the surgical techniques and post-operative complications. So the first case here is a very nice 71-year-old female with neck pain and upper extremity pain. She had some mild symptoms of myelopathy and radiculopathy, and she notices a lot of easy fatigability in her neck. She's tried a lot of non-operative treatment for this. She has a past history, which is notable for previous gastric bypass. And on exam, she has decreased range of motion in the cervical spine on all planes. She has some mild findings of myelopathy, including weakness in her hands and brisk reflexes. And if we look at her imaging here, we can see on imaging, she obviously has cervical kyphosis and significant degenerative disc disease. On her flexion extension views, you can sort of assess here that there's not a great deal of flexibility to her kyphosis. And if we look at her MRI, it does demonstrate stenosis and anterior osteophyte formation with disc collapse, especially at the 4, 5, 5, 6, and 6, 7 levels. And we went ahead and measured some of her alignment parameters. So you can see, and we'll get into some of these a little bit later, her elevated cervical SVA, her cervical kyphosis from C2 to 7, which measures 44 degrees, as well as her T1 slope there. And so when we're thinking about it, obviously some of the preoperative workup we like to obtain is bone mineral density, vitamin D studies, as well as a swallow study. And then hopefully some of the things that we'll get to discuss today is how to plan out levels, osteotomies, bone grafting techniques. So for this case, we elected to perform an anterior posterior fusion, performing ACDFs from C2 to C7, and then a posterior fusion from C2 to T2. And so this is kind of our alignment intraoperatively as shown on the fluoro. And then you can see here post-operatively our alignment parameters on her sort of day 1 post-operative x-rays. And then here at 1 year follow-up, she demonstrated a solid arthrodesis and fairly well-maintained alignment. She did have significant post-operative dysphagia, and so she did fail her first swallow study. We did place a PEG tube because of this. She did clear this in 3 months and it was removed. She still has some occasional dysphagia with large pills, but otherwise tolerates a full diet and no other post-operative complications. So when we think about cervical deformity, we obviously want to think about taking a good history, understanding the patient's main complaints, what prior treatments they've tried, including non-operative treatments and any other potential surgeries that they've had in the past. It's really important if patients have had prior surgeries to try to get the operative and discharge notes, because that can give you a lot of important information. It's also important to look at their past medical history to sort of determine the etiology, whether it be oncologic, traumatic, as well as assessing them for comorbidities like diabetes, osteoporosis, and smoking status. It's also sometimes very helpful to assess their preoperative swallowing issues, as we see post-operative dysphagia is very common in these patients. In addition to that, it's really important to assess the entire global alignment. It's often easy to get focused on the cervical spine and miss concomitant thoracolumbar deformities. And to really look at global alignment, both radiographically and in the clinic, and assess the patient's ability to maintain a horizontal gaze. And you can see there's kind of 2 different patterns here. This is a patient who's compensating on the right for a thoracolumbar deformity, whereas the patient on the left has both a cervical deformity and a thoracolumbar deformity as well. And so when we think about some of these factors, we know we've looked very carefully in the past at the overall alignment parameters for thoracolumbar deformities. It's been well described in the literature. But more recently, we've seen the importance of cervical deformity parameters. And so this paper by Tang in Neurosurgery in 2012 demonstrated better health-related quality of outcomes for patients with SVAs less than 4 centimeters after fusion. And so as a result, we've identified a number of important parameters, including cervical lordosis, C2 SVA, chin-brow vertical angle, as well as T1 slope as being important factors to look at with regards to cervical alignment and deformity. And when we look at some of these factors, there's obviously a lot of measurements to consider, but it's important to kind of look at the relationship between the T1 slope and cervical lordosis, because similar to pelvic incidence and lumbar lordosis, there's a spectrum, and we know that patients with large T1 slopes tend to require more cervical lordosis compared to patients with very small T1 slopes who can tolerate fairly neutral or sometimes even kyphotic alignment fairly well. And we know that for patients with a T1 slope falling outside of the ranges of kind of normal, which is 13 to 25, it's probably a good idea to get some full column radiographs, probably not a bad idea in general for these patients to fully assess their sagittal imbalance and to potentially pick up on any thoracolumbar deformities. The SRS swab classification is very, very well described and reviewed in the past, but we know that similarly, Ames and his colleagues have described a very good classification scheme for cervical deformity, including an assessment of SVA, chin-brow, cervical lordosis minus T1 slope, as well as measures of myelopathy and the Schwab classification for thoracolumbar deformity. And so we need to put together the whole picture of stability, deformity, neurologic issues, and the integrity of the soft tissues all together as one when you're making a decision about how to approach these cases. And one of the other things that Dr. Ames and colleagues have given us is a very nice way to describe ways to perform osteotomies in the cervical spine to help correct deformities. The most simple osteotomy obviously being performing an ACDF or resection partially of the facet joints posteriorly, then moving on to grade 2, which is a Smith-Peterson type osteotomy with complete resection of the facet and laminectomy, grade 3 being a corpectomy, and grade 4 being unsyntectomy, and then grades 5 through 7 being 3-column osteotomies, with grade 5 being anterior osteoclasis, grade 6 being a pedicle subtraction osteotomy, and grade 7 being a vertebral column resection. And so obviously, again, this case fell into the grade 1 category. So I think, with that kind of overview, I'm going to come back to the radiographs, because if I were to kind of critique my own work here, I think I had better correction of the SVA intraoperatively than I did on those immediate postoperative films. And so I'd kind of be interested to have our panelists weigh in, and maybe Dr. Nassr give us his thoughts about approaching this case.
Well, first I applaud you, Arjun. It's a great case, and I think it's always challenging. X-rays in these patients often look the best when we're immediately post-op, but we have to consider that the bone quality is probably not as good as somebody with normal alignment and probably normal function, and we do lose some of that correction if the bone is not great, and so we can lose that at the bone screw interface. If the patient is heavy set, potentially the rod diameter could make a difference. So I like, for a lot of these deformities, to use the largest diameter posterior rod that I can. So often I'll use a 4mm diameter rod if it's available for sticking with one diameter. If we can optimize their bone health prior to surgery, I think that's one way to help the bone screw interface, using the largest diameter screws and screw trajectories, using supplemental fixation in the cervical spine. Something Dan Root talks about is the lost art of using posterior tension band type constructs too. So, you're in the back, maybe utilizing some form of a cabling technique or wiring technique between the spinous processes to try to maintain some of that alignment as well. So I think there's lots of little tricks that we have up our sleeves that we can use to try to make it look better. But certainly I think we all have those patients where we look at that immediate postoperative x-ray, and then, a few months down the road, the alignment changes a little bit. I'm always suspicious that we're losing either some of that fixation at the bone screw interface, or possibly they're having other changes occur, slight decompression fractures of the lower instrument segments, or DJK starting to develop. So, but I think it looks great. Obviously, the most important thing here was address her myelopathy. So
I'm looking here at some of the comments. Someone was mentioning sort of the swallow issues and the PEG tube placement. At our institution, we tend to obtain a swallow study for all of these patients, both pre and post-op, and then based on how they perform on the swallow study, determine whether they need a modified diet, or in this case, when she failed it multiple times, placement of a PEG tube. Any of our other panelists have any thoughts with regards to management of dysphagia?
First of all, you did a beautiful job. This is very nicely executed in many ways, and Ahmed's comments are very insightful. I want to specifically point out the detail that in those peak spaces, which I don't like, I use pure allografts only. You put only one set of screws in so that you could still dynamically compress the spine posteriorly. So this little subtlety, I'm sure, was apparent to everybody, but I put a smile on my face. So the biggest point I want to add to that is we have to understand why people tilted their heads forward, and this is a multifactorial issue. I'm always worried that there's an element of myopathy in some of those patients. And if that is the case, again, that's multifactorial, then our best attempts at trying to straighten out the neck will suffer, not just necessarily from DJK, from just from poor posture, because I mean, you've done this, but then the rest of the thoracic spine just kind of sags down, and that's just an ongoing battle. So I think you've done a terrific job. In terms of the swallowing thing, this is not published yet, but I have a very low threshold towards putting PEG tubes in for so-called dropped heads a priori. Certainly for fixed kyphoses with significant decompensation. In my hands, again, even though I'm doing a very careful release and extremely cautious retraction, it is just so unforgiving. I don't want to go through the period of worries about it afterwards. I want to be able to start them right away. And so, and the other group of patients where I just do it, or I won't even operate on them, is the BMI challenged individuals. So if you're getting close towards the 18, I just don't see any benefit in waiting, and they just have to tank up before, and I usually want to have a PEG to them in there. So I'll shut up here. One question I had, Ed Farah has his hand raised. He's a great colleague here. Ed, can you just use a chat box or text me, and then we can put you in the panelist? And so your talking is activated. Ed, if you want to talk something, hit the non-mute button.
Okay.
We hear you.
Okay. I didn't mean to chat. I'm just observing and appreciating your insights. So I'll keep chatting to the minimum, and just want to thank you for doing the conference. So thank you, guys.
Arjun, just a few technical questions. Do you use a long oblique incision? Do you have an ENT guy help with the exposure? Do you monitor in any way while you're doing the case? And what do you do intraoperatively to kind of minimize your risks of postoperative issues related to the approach?
Yeah, that's a good question. I think I do tend to use, if it's going to be like a 5-level or greater ACDF, I tend to use a sort of J-shaped type incision. I actually divide something Brad Courier showed me. I divide that platysmal longitudinally so that I can get sort of more of an extensile approach. I try not to over retract. I deflate, have them inflate the cuff again. I'm assuming with monitoring, you're referring to the laryngeal nerve. Is that right? Or yeah, I don't routinely do that. And I also don't routinely have an ENT surgeon exposed for a sort of primary case. But for example, if this patient already had anterior instrumentation in or something like that, and I felt like it was going to be very scarred in, then I'd have an ENT surgeon exposed just to try to keep it as safe as possible.
Arjun, and for all the other panelists, do you think that the dysphagia is coming from the anterior dissection, or the fact that we're lengthening the spine when you correct the deformity and stretching the esophagus and all the associated soft tissues?
I would think the latter, because I don't see this degree of dysphagia in patients without kyphosis, even if I do a 4-level ACDF. Every patient that I've ever had to put on a PEG tube for dysphagia is a patient with kyphosis. So at least in my experience, I don't see the severity of dysphagia in just the exposure alone. And I think it's got to do something with stretch.
I mean, did the ENT surgeons have anything to glean upon this? I mean, if the curve is so many degrees, or we're stretching the esophagus so many centimeters.
Yeah, I don't know if the ENT surgeons have any literature on it. I'm actually going to present a paper a little bit later from the Cervical Deformity group, showing that they couldn't find an association with dysphagia and degree of correction. But that being said, they only looked at dysphagia at 3 months, and most of these patients, at least in my experience, and I'd be interested to see the other panelists, most of these patients, their dysphagia resolves around that 3-month mark.
There may be also a biologic process that's going on in these patients with kyphosis. I mean, we know that not every patient develops this. So what's the biology here? And often the ALL will be very thick in these patients. And, the amount of soft tissue between those anterior osteophytes is also, my experience has been, if we see a lot of kind of prevertebral soft tissue that's really thickened, that's probably also a sign that they may have more dysphagia as well. Just it's a stiff kind of spine, and maybe that stretch is not just it's not just the mechanical stretch, but some biologic reaction that the esophagus is having to that stretch. Because I agree with Dr. Sebastian. I routinely do 5, 6, 7 levels in the front, and don't have dysphagia if they don't have a deformity. But the deformity, if it's not associated with very large anterior osteophytes, often still doesn't have as much dysphagia. So you can correct, for example, some post-laminectomy kyphosis patients with really horrible kyphosis, but if it's a result of losing their posterior tension band, they don't also have as much dysphagia, at least in my experience.
It might be interesting to look at corrections using shortening type osteotomies versus, lengthening type osteotomies, us staying posterior. So that might be a nice little fellow project for one of your guys is, try to find some matched patients with similar preoperative deformities and see whether the ones who had a shortening type procedure versus lengthening had a differential in their dysphagia. We might learn something from that.
Yeah, that's a great point.
There's also another question about whether or not we use 1 or 2 neck incisions. And I think, Dr. Sebastian already kind of mentioned this, is that kind of a larger incision. I still use a fairly transverse incision. And one of the things, again, I think is really critical is just spending that extra time, either doing a longitudinal platysmal dissection and doing a subcutaneous dissection, or subplatysmal flaps that are really extensive. But with a transverse incision, you should be able to see from C2 to T2 pretty easily without a ton of retraction. And it just takes a little bit more time in that superficial dissection. So, if you had to use 2 incisions, I don't think anyone would fault you for that, though.
So I think great discussion. I think with that, we'll try to move on to our next case, which I'm going to try to pull up here. All right. So coming to our next case, or our next patient. RC here. So this is a 71-year-old male with neck pain, hand numbness. He had a previous C3 to 7 laminectomy for myelopathy. Did very well for about 3 years with that, and then had recurrent symptoms, hand dexterity issues, gait issues, and a left upper extremity radiculopathy. He also, similar to our last patient, started noticing issues with maintaining horizontal gaze. His history is notable for coronary artery disease, COPD, diabetes, as well as Parkinson's disease, which obviously is always a concern anytime you're thinking about a fusion. And if you look here on exam, he has loss of cervical extension and other findings of myelopathy, including hand weakness and left triceps weakness. These are his images, again, showing the previous cervical laminectomy and kyphosis. He has some component of ankylosis as well. and on his flexion extension images, maybe just a few degrees of change from flexion to extension. Looking at his alignment parameters here again, he has about a 28-degree kyphosis with a 5-centimeter SVA, and evidence of cord compression and OPLL on the cervical MRI there to the right. It's a little bit easier to appreciate the cord deformation in this setting on the axial images, and then the cross-sectional sagittal image CT showing again the OPLL. So in this case, we opted to, because of his kyphosis, treat this starting from an anterior approach, doing a C6 corpectomy, and then C2-3 and C3-4 ACDFs. So this is one of my earlier cases when I first started out in practice, and I can tell you when we started doing the posterior resection, I was glad to have Dr. Nassr available, because it was a very challenging decompression in the back and very hard to find any plane. Ended up having to essentially resect that entire posterior wall. There isn't really any dura left there, and so ended up placing some DuraGen DuraSeal for that. And then went in the posterior and essentially did a C2 to T2, or sorry, T3 posteriorly. And these are our immediate postoperative images and a post-op CT scan showing that resection of the OPLL. And then these are 2-year post-op images, again, showing that he went on to solid arthrodesis with good improvement in his alignment, and thankfully no major issues. You can see here, this would kind of fall into the grade 3 category in the Ames classification in terms of osteotomy. We did manage his intraoperative CSF leak with the head of bed elevation, keeping him upright for 48 hours. He also had some swelling issues, which resolved at 2 months, as well as some root palsy, an increased C7 weakness on the left side, which resolved at 3 months as well. So this was kind of the study I was talking about a little bit with regards to swallowing. This was from the International Spine Study Group, showing again that patients with cervical kyphosis had baseline swallowing dysfunction, but didn't seem to show any significant differences compared to a non-kyphotic group with regards to dysphagia at 3 months, and really no differences with regards to the degree of kyphosis correction. So with that, I think we'll go back to the x-rays here and maybe open up to the panelists for any thoughts or any comments.
Yeah, can I ask a question? So 2 questions. Number one, the CSF leak, was it anterior or posterior?
That was anterior.
Anterior, okay. And then what was interesting to me was on the MRI, it almost looked more like cord atrophy rather than cord compression. But then when you showed the CT scan, there was obviously cord compression. So my question is, did he get any better?
You know, I wouldn't say that he got better as much as he sort of didn't feel like things got worse. So his gait improved, but his hand function never really improved. And so I think that's a great point. But you know, we kind of discussed with him, as we do with all myelopathy patients, that, you know, goal number 1 is preventing progression, and then we hoped that he would sort of see some improvement.
And Arjun, how did you find the plane posteriorly? Because the canal was wide open. It must have been a mess.
Yeah, you know, going into the case and reading about, you know, especially the Japanese write a lot about, you know, resecting OPLL or potentially floating it, you know, away. And so my plan was to try to do that, was to try to find the lateral edge and kind of float that OPLL away. And, you know, even when I felt like I went as lateral as I felt comfortable with the corpectomy, you know, I was still not finding a clean plane. And so essentially that's when I had Dr. Nassr help me out. And by the time we were done, there really just wasn't any dura anywhere, you know, all the way out to the roots, you know, the C7 roots. And so again, you know, I think just another illustration about how challenging it can be to resect OPLL anteriorly.
Yeah, I remember helping on this case. It was interesting that even the dura along the ventral margin of the roots all the way out past the level of the pedicle was ossified, and which is fairly impressive because I have the similar experience. To be able to, if you just keep going lateral, you eventually find kind of native dura, and you can avoid actually getting into the OPLL mass. But here we got out pretty far. I think we took out the uncinates, I think, to try to find native dura, and we just couldn't find anything that didn't look like bone. The post-laminectomy kyphosis patients, I think, in some ways are also challenging because we have to remember that MRI is obtained supine, and so if they have some degree of correction, it often looks better on the MRI than they are clinically. And so if it is an atrophic cord, and I think this patient had Parkinson's, I'm not sure, but probably in patients with Parkinson's, they naturally have a high tendency to fail whatever we do in spine. But if they have a movement disorder, an atrophic cord, their cord's really not going to tolerate very much. So even just that little bit of kyphosis is enough for him to kind of keep on probably compromising his blood flow to his cord, getting a dynamic cord compression. So I guess in hindsight, maybe one could argue to do this all posterior and just fix them, without the anterior component, knowing how hard it was when we actually tried to take this out. But I do think we took out that kind of big bump there that was really causing the deformation of the cord. So.
Just out of curiosity for the panelists, anybody doing cervical laminectomies alone for short segments or really sick patients? I'm just curious.
You mean for short segment OPLL, Arjun?
I mean, for patients who have cervical myelopathy, who maybe, you want to avoid fusion in, or for whatever reason. I know, that's something that I still see being done is cervical laminectomy alone. And I was wondering if anybody is doing it for special indications or anything like that.
And Todd is on the phone right now. I'd love to hear his thoughts on doing these little flavectomies that I've seen where you preserve the PLC and you undercut the lamina selectively at several levels. So I've seen some neurosurgical colleagues do that. I'm 100% with you and Ahmed. I revise failed laminectomies all the time. And it's one of those crazy things because the literature has actually never given us really hard and fast data on that. There was a Sargent paper that basically on a prospective foundation identified a roughly 30% incidence of severe deterioration. And again, being an older person, not having worked with older neurosurgeons, they always said, oh, they violated the facets and they went too lateral and they went too many levels. But I think it's a flawed procedure in general. So I have zero evidence of what these multi-level little flavectomies do. I don't know whether you see it in your areas. I have seen it described, and Jeff Wong and Dan Wu both talk about doing that, but I have no direct prima facie literature or clinical experience with that.
I mean, do you still do anterior resections for OPLL? Because I learned that lesson after one or two cases and try to avoid that like the plague. So I've never had a nightmare case like it sounds like you did. So do you still do it just when you're forced, or is that still something you try to do primarily?
Yeah, I mean, if I can avoid it, I try to. So anytime I see that, or if I see a lot of hypointensity on T1, then they get a CT scan, and if I see any hint of OPLL, then I'm going to try to do it posteriorly. In this case, I felt like with his kyphosis, he was kind of draped over it, and so we were kind of stuck. But maybe we could have gotten realignment from the back and resected the laminectomy membrane and at least gotten an MRI to see what we got. But here he had such a thick ball in the middle, I sort of felt like he needed it.
Yeah, this is a very challenging case given the constellation of the OPLL and his Parkinson's. My question to you all is, do you use a movement disorder clinic? Because I have so many Parkinson's patients around my clinic all the time, and it's one of the most humbling patient clienteles to work with? And do you differentiate different types, as we now know, of Parkinson's in terms of the specific types of movement disorders as to what body control they can exert after even a successful surgery like yours?
I do have them see our neurologist to make sure, they're sort of on the right medications and regimen. In this case, he was already kind of plugged in with our neurology team. And so I kind of had faith that he was as optimized. Certainly if it was a patient who came from somewhere else, I may refer him to our movement disorder clinic for evaluation. As for sort of approach based on the different types of Parkinsonism, I can't say that, I've been tailoring it in that way, but I'm sure maybe someone else has experience in that.
I'll comment that I think the real disasters are like the aphetoid movement disorders, where they really just have no body control. I mean, if somebody comes in and they're doing this constantly throughout the evaluation, I don't think they're a candidate for spine surgery until that's really optimized. And if our neurologists are really shy about sending them to one of our deep brain stimulation people, I will often insist that they have an evaluation with a deep brain stimulation functional neurosurgeon to see if they can optimize that even better. All of the patients that I've had super early failure of their instrumentation fall into that category, the aphetoid Parkinson's patients. And I just don't think we can combat that. Even with the Parkinson's, it looks like it's in really, really good control. At one point, we did a retrospective review of our Parkinson's patients at Mayo, and the failure rate of their instrumentation, so instrumented fusions in that population had about a 50% failure rate. And so I think what we're coming to recognize is not all Parkinson's is the same, in that well-controlled Parkinson's probably behaves better than somebody with an underlying movement disorder where it's untreated. We're very fortunate that the vast majority, by the time they get to us, have been through our movement disorders kind of neurology section. And so they often are well controlled. And so I think we have the luxury of kind of that resource, but I would certainly encourage anybody that's listening to this talk to really have a healthy respect for Parkinson's and other movement disorders, because when I see that, I get very afraid, and I have very long conversations with them about, the possibility that the surgery doesn't pretend a good outcome. So.
Well said. Hey, I wanted to ask Todd quickly, since he's on there. So by the way, shout out for deep brain stimulation. It is amazing. And I think we as surgeons can do a good job by sending Parkinson's patients to functional neurosurgery colleagues earlier, bypassing some of the neurologists. It's an ongoing culture war that I see that's very interesting. But I've been highly impressed with DBS in earlier patients, and I know that's not the general consensus. Todd, we talked about, Arjun asked a great question, multi-level laminotomies, full laminectomies without hardware. Where do you stand? I know that I've seen pretty cool looking images by some of our colleagues at the joint sections where they do multi-level laminotomies, leaving a PLC intact and just nibbling out the ligamentum flavum. What are your thoughts on uninstrumented laminotomies or laminectomies in this era? Todd, you got to unmute.
I'm sorry. Jens, I just found out I had to have another surgery Friday, so I'm a little off kilter here. Repeat the question to me. I'm sorry.
So Arjun had raised the question, in this era, is there a role for laminotomies or laminectomies without instrumentation of the cervical spine, like under PLC preservation, nibbling out the ligamentum flavum, undercutting the lamina? Is there any role for that anymore?
Yes. Yeah, I think there is. I think that, I've done this actually in arthroplasty patients who have some continued posterior compression. Typically when you do an anterior cervical, you relieve most of the compression because most of the disease is anterior. So then when you approach, and if they still have residual symptoms, it's reasonable to approach posteriorly and then do a microlaminotomy for aminotomy and decompress posteriorly. And I do that via laminotomy, not a full laminectomy, of course, because I want to preserve ligaments and maintain stability. So I think there is still a role here. for that. Yes.
Great. Well, I think that was a good discussion, and maybe we'll get to our next case here to keep things kind of moving along. So I'm going to share my screen here again. Just give me 2 seconds. Sorry about that. All right. So our next case, kind of moving up the deformity ladder here. So we kind of talked about a grade 3 osteotomy in this situation. So our case 3 here, KT, this is a patient who presented with more of a sort of classic chin on chest deformity. She's a 65-year-old female who underwent a posterior instrumented decompression and fusion in July of 2020. September, she developed worsening weakness and instrumentation failure and underwent an anterior cervical fusion at the same facility. She then began developing progressive chin on chest deformity and dysfunction of both gait, hand function, bowel and bladder dysfunction, and was sent to us for further evaluation. She does have a significant past history for COPD and osteoporosis, and the prior surgeries is noted. On examination, she presents with a fairly severe chin on chest deformity, really minimal, even passive extension, fairly significant weakness in her hands, and findings of myelopathy. And these are her presenting radiographs showing a 60+ degree cervical kyphosis with evidence of instrumentation failure distally at the posterior construct, and kyphosis really centered at that C7-T1 disc space. We obtained a CT scan, which demonstrates some evidence of ankylosis across that C7-T1 disc space, as well as instrumentation of failure posteriorly and pullout. And then on MRI, she had a fairly significant post-laminectomy membrane and cord compression associated with her kyphosis. So, you know, to sort of get a feel for what was going on and given the complexity of her deformity, I planned for a sort of a first stage removal of hardware and placement into cervical traction. Given the severity of her deformity, we weren't really able to access the anterior instrumentation, but took the posterior instrumentation out and placed her in traction for 48 hours with not a whole lot of correction, and then obtained a CT scan with her in traction, again, kind of re-demonstrating the findings from her earlier CT. And so based on this, we're trying to kind of figure out what to do for her. I talked to a lot of my colleagues and ended up deciding to do a posterior approach with instrumentation from C2 to T9, resection of her laminectomy membrane, essentially a Smith-Peterson type osteotomy at C7-T1, and then actually utilize the navigated osteotome to perform kind of an osteoclasis through that disc space from a posterior approach, and then came back and performed an ACDF at C7-T1. So this was our images after the posterior procedure. You know, fairly challenging to resect that membrane and perform the Smith-Peterson osteotomy at 7-1, but then really, you know, took advantage of the navigation to kind of work through the disc space posteriorly and perform a release of that bridging fusion mass anteriorly, leaving that kind of gap after we kind of performed a cantilever correction technique, and then came back in the second stage and performed an ACDF at C7-T1. These were her 6-week radiographs. She was doing quite well at that point. And, you know, when we classify this, I think it's best classified as a grade 5 type osteotomy, sort of a SPO in the back, or grade 2 with the addition of an anterior osteoclasis. She also, like a lot of these patients, required a PEG tube placement. At that 6-week recheck, was doing very well. Unfortunately, we were notified at about 3 months post-operatively that she had developed COVID-19. She went on to develop sepsis and respiratory failure and ultimately passed away. So, you know, obviously a sobering outcome, despite what we thought was a good radiographic outcome. You know, this is not the first description of, obviously, this technique. It actually goes back to the 1950s, described doing, you know, essentially an osteoclasis from a posterior approach for patients with ankylosing spondylitis. Obviously, this description and this type of technique is a little bit risky because you are lengthening the spine, so you do have to be quite careful. But it was just interesting to see how early these techniques were starting to be sort of experimented with. In terms of resection of that posterior laminectomy membrane, I think that's another sort of challenging thing. And these are some pictures Dr. Nassr has from one of his cases. I think it's really helpful to find that bony edge and some native dura, and then you can kind of use the cautery and a Cobb elevator and kind of carefully peel it back. Luckily, the cervical dura is pretty thick, so sometimes you're able to kind of find a nice plane and resect it. I do think it's important, though, before you do the correction like this, that you resect it. Otherwise, when you do your correction, I think it's that scar is thick enough that it'll cause significant infolding and injury to the cord. So with that, I'll kind of go back to the images here and open it up to our panelists for their thoughts and a little bit of discussion.
A great outcome, Arjun. I think this is obviously a very challenging case in a very poor host, and you often wonder, like, again, how many of those complications happen just because of our osteoporosis, which is, it's really just, I think, almost a national crisis right now, and how many people have such poor bone density. Maybe if we had, treated that patient prior to any of those other surgeries, maybe you wouldn't have had to do such a drastic operation to her. The correction looks great. I think obviously there's some fear of doing osteoclasis type surgery now, and the shift has been maybe to push our osteotomies further and further down, trying to do T1 or T2 PSOs. But sometimes that's not where the apex of the deformity is. And I think you did the right thing here. And I think it probably would have been a lot more unstable if you didn't go back in and plug that hole in the front. So I applaud you. I think you did a great job.
I was curious about that as well. Would anybody have attempted something more aggressive from the front or tried to, I felt like in this case, you'd need to do a sternal split or something to get down there. Any thoughts from the other panelists?
Sternal splits, having done those in my earlier years, are a maiming surgery. Patients are generally, in my experience, very unhappy about those. And I've had a fair number of patients come to me with complex situations. I've gone away from sternal splits. We have excellent cardiothoracic surgeons there. And I've been very happy, and I need to point out Dan Rue's great contribution towards showing us how much you can do at below C7 at T1 and T2. It's really changed the game for us in terms of redeploying the head on top of the shoulders and getting the occiput over the gibbous of the thoracic spine. So I echo what Ahmad said. This is a unbelievably challenging case that happens more and more often due to a variety of factors, and correcting those is truly a substantial challenge. For me, the one question is, how low do you go? And in these osteoporotic patients, how do you prevent DJK? Do you use cement? Any tips and tricks in terms of how to prevent them from just keeling over yet again would be welcome. Thanks.
Yeah, so at least for me in this case, I wanted to make sure that our distal end of the construct got past the apex of her thoracic kyphosis. I wanted to get into the lower thoracic spine. I've seen a number of papers from the ISSG kind of arguing about where that stopping point should be. But I think, again, you just want to get past the apex of her thoracic kyphosis to hopefully minimize the risk of DJK. I haven't cemented to try to prevent DJK. I've done that for PJK in the past. Ahmed, I know you have a little bit more experience with cement. Any thoughts there about cementing the distal construct?
I have. I'm starting to see my cement failures come back as well. So I don't know that there's any magic. I think the more and more you hear people getting aggressive on this, I think a lot of them are dropping like a C7 plumb line or a C2 plumb line and trying to figure out where along the spine that intersects And if you actually look at that really carefully, it really doesn't intersect until about L2 or L3 in a lot of these patients. And so even if you stop at T12, which you would think that's well past the apex, people are still reporting fairly high rates of DJK. So some of the more aggressive surgeons in terms of, just thought process have said, well, you need to get to that line where your sagittal plumb line intersects kind of an anterior vertebra. And that's often, mid-lumbar spine segment. But in my experience, even in very long constructs ending at L2 or L3, they still have failures. And so some people will argue that if somebody's had so many osteoporotic failures, you don't stop short of the pelvis, right? So, because you can't really DJK into the pelvis. Well, I'm sure you can. Haven't seen too many of that yet, but I would say that, I would argue that I think the lesser of two evils is just to go past the kyphosis, make sure that your instrumentation is not prominent. I've been using a lot more sublaminar fixation strategies, so sublaminar polyester bands of some sort, because the laminar bone is a little bit stronger. And then I'll clip on to the rods to protect the distal screws. And I have been cementing some of those lower screws as well. So.
Yeah, I think all good points. And I think just like all of these cases really highlight the issues with bone quality and having a good endocrinologist that you can work with to try to optimize these patients before surgery. So with that, maybe we'll jump into the next case again, kind of going up in terms of the deformities and the osteotomies. So we kind of talked about here again, this being a grade 5. Jumping ahead, this is a case courtesy of Dr. Courier. This is a patient that was referred to him having had a previous occipital cervical fusion down to T2, developed a progressive deformity with an elevated chin brow, as you can see here. And on the MRI, as you can tell, there's compression deformities throughout the upper thoracic segments, which are pointed out here. And you can also see on the x-ray a little bit more closely that the T2 screws have fractured. And so in this case, given this sort of cervicothoracic deformity with distal failure, Dr. Courier elected to perform a C7 pedicle subtraction osteotomy, so kind of a grade 6 osteotomy in this case. And you can see here the beautiful correction of alignment from pre to post-op. As this image shows here, just like any PSO, when you do a pedicle subtraction osteotomy, with the superforamen, the 7 and 8 nerve roots can get quite tight. And so this patient did have some post-operative unilateral triceps and a C8 type weakness. CT scan did show some evidence of residual foraminal stenosis, which was taken back, was re-decompressed and did improve with long-term follow-up. So again, kind of a good example here of a more advanced sort of grade 6 osteotomy. And so with that, I kind of open up to the panel, in terms of thinking about cervicothoracic deformities and pedicle subtraction osteotomies at that level. Are more people erring towards sort of proximal thoracic versus C7? Anyone have any thoughts?
Well, I'll venture in on that. So first of all, great case. Again, long deformity patients require lifelong follow-up from us to just interact early and decode it relatively early before you had a complete disaster. As we correct these cervical thoracic deformities, two first thoughts I want to venture out with. Number one, I've become very leery of the C8 root. Again, understanding and being cognizant and protective of the C8 root. I don't want to say more than the T1 root, but on a high level is really important, because patients so much need all of their cervical roots, but especially C8 is just very incapacitating for patients. The second thing is I'm not a great friend of the PSOs at C7, T1, T2, because the patients then walk around like this. They kind of have a very unique posture. So I've started actually using the shorter expandable cages from the back between the roots, and I expand the anterior column, expanded to an original height again until they have a pretty much normal alignment. And that's been very successful and gratifying in my hands. So those are just two observations. C8 root, gotta watch that and can't let anything happen to it. And personally lengthening the anterior column so it's physiologic. And that's more an aesthetic thing than a functional thing. Thanks.
I think we may have Brad Courier on. I'm not sure if he's in the ability to comment here, if we can allow him to have access to the mic. But Brad, we'd love to get your thoughts since it's your case as well. But I think my tendency is that I've been shifting my PSOs lower to T1, T2, or even sometimes T3. T3, the risk really to the roots is pretty minimal. Occasionally you still want to do it at T2, but if you can make an argument for that and then go a little bit longer with your posterior thoracic construct, that's also a nice way to potentially get out of trouble with the roots, trying to get them to come through that tighter frame.
And I agree. I think that, the C5 root and the C8 root and the L5 roots are the roots that aren't agreeable to much manipulation. And so I've tended to go lower at T2, 3, 3, 4 for correction, as you were mentioning. And I think that's safer and better neurologically. The goal is obviously to reconstruct sagittal alignment as well as protect neurologic function. So it's a balance between all of that. And but I'm inclined to go lower as well to T2, 3, 3, 4.
Also, just technically, it is actually easier to do the PSO at T2 because the body's a little bigger from top to bottom. So at C7, you're limited by the roots because the size of the pedicle as well is not that big. By the time you get to T1 and T2, the pedicles are much larger. So PSO is actually a lot technically easier to do, and you can get more degrees of correction, I think, as you go a little bit further down.
Yeah, 100% correct.
I think I'm unmuted now. Can you hear me?
Yes.
Oh, great. Yeah, I agree entirely with your comments, Jens. This was an older case when I was doing C7 PSOs, and that foramen, that conjoined foramen, is much, much smaller than you would think. Doing lumbar PSOs is an entirely different deal, where there's lots more room for those two nerve roots going through there. And you're absolutely right, a C8, even a T1. So I tried to avoid, when we were doing vertebrectomies, I tried to avoid T1 also because I didn't want to injure that T1 root, because that also gives disabling hand weakness oftentimes. And so doing this at T2, T3, I think that's a much better option.
Yeah, those are all great comments. Thanks for joining us, Brad. I guess one of the questions I've always had, and I think it was the same in this case, and I'm sure we've all had cases like this, these root level issues don't get picked up well with our neuro monitoring. So I think in this case, there were no changes in MEPs or certainly SCPs. Has anyone had any experience with maybe some monitoring techniques that are more sensitive for root level issues, or anything along those lines?
I think the key thing that I've learned is, and we're under heavy pressure because there are administrators who like to take away neuro monitoring. The more you use them, the better they become, and the more you have close interactions. I see some nodding heads like from Jack. I mean, it's really a big deal, and I've become a big fan of them. And then ultimately you have live wire EMGs, and we will have probably a direct conduction capability with one of the Southern California companies in the very near future that's working in that space, and we're very excited about that.
Yeah, we use live EMG and find it very useful for that issue. And you know, it's really dependent on the examiner and your technician, because just like when you order an EMG, you know, 90% of the EMGs you order are not really usually beneficial in my experience, but I have a few guys I totally rely on that are accurate and reproducible, and same in the operating room, where I have reproducible results over and over. And I think it's getting really great technicians that give you live constant EMGs that help you with that. So it's hard to discover those people, but when you find them, you latch onto them and you develop them, like Jen's mentioned.
There may also be a role for triggered EMG as well, although I don't have as much experience in the cervical spine doing that. But in the lumbar spine, when we do high-grade spondies, you may not get any free run EMG when you're correcting a high-grade spondee. But if you do triggered EMG, you'll often see an increase in threshold from the root. And that's a sign maybe that root is really struggling, even though it's not showing up on an MEP or SSCP change. So.
And so as we're nearing the end here, I saw, you know, Dr. Champion, you kind of mentioned issues with neuro monitoring and getting pushback from hospitals. I've had a number of recent denials for, you know, neuro monitoring for cervical cases now. Are you guys seeing that out in Seattle as well?
It's the same story, I think, all over the country. They're trying to cut corners here and there. And it's our problem that we are doing very well 99% of the time, and they don't see the value of the continuity. And all I say to that is one med mal case with an adverse outcome that could have been seen on monitoring, and you have a double digits 7+ figure settlement in front of you plus bad press. So the penny wise, pound foolish equation certainly applies here. I think we're at the closing hour almost, but yeah, I mean, I don't know anybody who would want to do these kind of cases without excellent monitoring. I totally agree with Todd. Having a close working relationship with these people where you can then trust them is a really big deal. They're not contractors. They need to be with you often. They need to know what you're doing. And from a documentation standpoint alone, it's superb to have that extra set of documentation parameters.
Yeah, I couldn't agree more. Well, I think we'll, you know, wrap it up there. We're getting kind of near the hour here. Any last comments or questions?
No, thank you, Arjun. They were great cases, and you know, it was terrific to see how you managed them.
Thank you.
Yeah, I really appreciate this topic as we discussed in the precursor. One thing I want to make a pitch for is the so-called recumbent test. So we obviously rely on a lot of x-rays, and we have supine CT and MRI and then upright x-rays. But I think the clinical assessment of a patient laying supine on the exam table and then clinically measuring how flexible that neck is and how much the distance in finger breadths or so from occiput to plate. That's one thing that I really think we all together could probably push more and maybe formalize in form of a study or something like that.
All great points. Well, thanks everyone. Thanks for joining this evening, and thanks to Seattle Science Foundation again. It was a pleasure.
Thank you, guys.
Thank you.
Everybody stay well.
Thanks, guys. Thank you.
Yeah, good night.
Good night. Thanks, Linda.
Thanks, guys. Bye-bye.
Take care, Todd.
All right,
Good
you
luck.
too. All right, guys, bye.